Today, I want to touch on the issue of COVID-19 vaccine hesitancy among Black Americans, as Delia mentioned, the inequity issues underpinning it, some of the research I have done in collaboration with my colleagues at the Annenberg School for Communication at UPenn, and finally, some of my thoughts on future research efforts in this area. So as we all know, the COVID-19 pandemic continues to have a global impact on communities and populations. However, the consequences of this current public health crisis have not been equally distributed. In the United States, marginalized populations have borne the brunt of the pandemic, among which are Black Americans. Compared to whites, Black people in the United States are 1.1 times more likely to test positive for COVID-19, we're almost 3 times more likely to be hospitalized as a result of COVID-19 related complications, and are about twice as likely to die upon coronavirus infection. These disproportionate outcomes are not happening by chance or anything pertaining to individual level decision-making. Rather, our population is experiencing this unequal burden because of the social determinants of health. And the social determinants of health refer to the non-medical factors that influence health outcomes. These are conditions which are born, where we grow, work, live, play. These all affect our health and well-being, as do the policies and institutions that make decisions on these conditions. Because these conditions are dependent on institutions and systems, Black people are more likely to live in environments where said conditions are not up to par and are intentionally neglected due to institutionalized racism. Black people in the United States are more likely to reside in overcrowded living conditions, less likely to be able to work from home, and are more likely to have a working environment where social distancing is difficult. And the lack of access to healthcare, healthy food, and clean environments lead to compounded chronic illness that make us high risk for COVID-19. With all that being said, what this means is that these disproportionate yet preventable impacts of the pandemic must be met with intentional and purposive strategies to mitigate the harm and burden that our population is experiencing. At this current moment, immunization is the most promising pathway to an end of this current crisis. However, despite the documented success of vaccination as a public health innovation and important tool for prevention, vaccines are not always accepted by everyone in the population. Vaccine hesitancy has been defined as the delay in acceptance or refusal of vaccine services. It is highly context-specific and complex as a phenomenon, such that what we learn from vaccine hesitancy in one disease area may not be transferable to others. And thus, the World Health Organization has identified vaccine hesitancy as among the top threats to global health because of the implications of vaccine refusal of even a small proportion of people for the well-being of the greater population. In the context of the COVID-19 vaccines, Black adults are least likely to report wanting to receive a vaccine when they're able to, despite cost. Of course, financial and structural factors play a role in whether or not one would want to, but controlling for these issues, vaccine hesitancy remains higher among Black Americans. And the study I will soon delve into will explain a bit more of that. These charts are just some illustrations of vaccine hesitancy across different demographics. A number of organizations have been collecting data on vaccine hesitancy since March 2020. And although vaccine hesitancy has gone down over time throughout the population, Black adults remain among those with the highest level of hesitancy still. This data in particular is from the Kaiser Family Foundation Vaccine Monitor. On the right is data from December 2020, and on the left is from January 2021. On the right, we see that Black people, compared to all others, are least likely to report that they would, quote, get the vaccine as soon as they can, unquote, and more likely to, quote, only get the vaccine if it is required for different activities. On the left, we see again that when comparing racial demographics, Black adults are reporting wanting to wait and see at higher proportions. Now, waiting to see or learn about novel medical technology or healthy skepticism in of itself is not unwarranted, but the drivers of the hesitancy, the particular beliefs fueling it, are what's important. For example, is misinformation exposure driving the hesitancy as opposed to gaps in knowledge surrounding the vaccine? The places we get our health information from play an important role in the health decisions we then go on to make. In the context of COVID-19 vaccines, as in other health areas, trusted messengers are important, as Delia mentioned. Whether one trusts a health information source will influence whether they take up the advice of that messenger. For example, research shows that health professionals tend to be the most trusted source of health information across demographics, which is a really good thing because typically our health providers are well-informed experts who are meant to have our best interests in mind. However, in our social networks, both online and in person, there are also people who we trust health information from. But when these individuals are not experts, it's possible that they might be conveying misinformation, whether intentionally or not. Additionally, media platforms from which we might be receiving health information also play an important role in shaping our health beliefs and decision-making. Given factors such as partisanship in the United States, the way the pandemic and the vaccine is being discussed in the media will vary. Also, given the lack of gatekeeping and editorial policies, social media is more likely to contain misinformation than traditional media. In sum, these information sources can shape your health-related beliefs and subsequently behavior. In a survey study I led in my research lab seeking to understand COVID-19 vaccination intentions among Black Americans, we explored the relationships between related beliefs and COVID-19 information sources. At the time we collected this data from May to July 2020, the COVID-19 vaccine discourse was being heavily shaped by partisan influences, given the president at the time and how he was handling the pandemic. Media platforms were also not impervious to these influences, and misinformation on the pandemic in general was pervasive in both traditional and social media. Thus, we were interested in seeing what role prominent messengers and different media platforms might be playing in the vaccine hesitancy observed among Black Americans. So we probed a battery of 6 COVID-19 vaccine-related beliefs among our participants. Note that at the time of the study, the topic of COVID-19 vaccine hesitancy had just risen to the 4 public health priorities. So the beliefs we probed in our questionnaire were adapted from both vaccine hesitancy literature and early reports of concerns that came up in the media. We wanted to see first if comparing Black participants to whites to all others, whether these beliefs varied by demographic, and they did. Then second, and most importantly, we wanted to see if holding these beliefs actually had a relationship with vaccination intentions. Then our third research question was to see if trust in COVID-19 information sources, specifically trust in public health officials, the former President Trump, social media, and traditional media, is differentially affecting beliefs of Black respondents versus those of others. So what we found was that the vaccine-related beliefs were significantly related to people's intentions to vaccinate, as in the attitudes they held towards vaccination is what was predicting whether they would want to get vaccinated, not just the fact that they were Black or any other race. And further, overall, Black people were less likely to hold favorable beliefs toward COVID-19 vaccines, suggesting more vaccine hesitancy, which is then reflected in their lower vaccination intentions. These figures are a representation of the relationship between 4 of the 6 beliefs we looked at with intentions to vaccinate. The slopes of the lines are the same, suggesting that the relationship between the intentions and the beliefs are similar, but what's different is the main beliefs themselves. For example, Black people are more likely to strongly agree that they would suffer bad side effects from the vaccine compared to others, and also more likely to strongly agree that they can trust vaccine information from public health officials. As for our last research question on the differential effects of COVID-19 information sources on beliefs, we didn't observe any significant findings, leaving more room to further explore that pathway of the role of certain trusted messengers. So despite the interesting results we observed in the previous survey study, there's still a lot that remains unanswered, specifically when it comes to developing a health communication strategy meant to address COVID-19 vaccine hesitancy. The coronavirus is a novel health issue, and given the highly contextually specific nature of vaccine hesitancy, data needs to be collected directly from the population of interest on their specific concerns. And this is a goal of formative research. Formative research will allow you to get an understanding of the set of issues that are serving as either barriers or facilitators to adoption of particular health behavior in the population of interest, which can then inform a public health communication effort. Formative research will also allow you to then take this information and develop tools for public health surveillance, specifically survey tools to track and follow these particular beliefs to see how they are changing over time, how they're impacting behavior, and how they're differentiated across those who are adopting the behavior versus not. In this current crisis, there is a need for urgent response to an issue like vaccine hesitancy, but it should not ultimately supersede the importance of collecting data directly from the populations we care to impact. Involvement of the targeted populations is crucial for the effectiveness of the intervention strategies we aim to deploy, which mirrors what Dr. Wesley was discussing in her segment. Therefore, conjecture among experts will not suffice because we are experts in our fields, but not in the lived experiences of others, despite being members of those communities ourselves in certain cases. There are a number of ways one can carry out formative research. These include interviews, focus groups, elicitation surveys, social media analyses, literature searches, and more. But given limitations of each approach, a few of these methods are typically deployed in tandem in order to triangulate on the most prevalent set of issues. As I'm in the early phases of my dissertation research, I put out an elicitation survey as one of the first steps of this triangulation method. I surveyed Black adults across different age groups, asking about their concerns surrounding getting a COVID-19 vaccine, and these are some of the verbatim responses that we received. Concerns of side effects and other health consequences are common. They mentioned individuals who would be influential in their decisions whether or not to get vaccinated. And they also mentioned some important barriers such as inaccessibility and long wait times. This type of information, which is directly from the population of interest, is what is important to know when trying to address vaccine hesitancy and other issues related to vaccine accessibility in this particular context. It will give the public health community an idea of what issues to address and either communication strategies aimed at encouraging vaccination, as well as systemic issues that are serving as barriers. Finally, although vaccine hesitancy and lower intentions to vaccinate among Black adults continue to be present, what we're seeing with the current rollout is that access is an important issue. There's not enough supply to meet the demand of those who want to vaccinate. There are gaps in information and the sign-up process and eligibility. There have also been reports on more affluent people coming into low-income communities to take up vaccination slots, and data showing that even within healthcare workers who had been prioritized in the rollout, Black healthcare workers are being vaccinated at lower rates. Essentially, while hesitancy will likely remain an issue, there are other issues that have arisen in this current moment that communication priorities might also need to reorient to address where possible. So these are some of the areas that future work would serve to delve into. However, regardless of the directions this dynamic moment takes us, we must be centering the needs and voices of the populations we serve if we want to continue changing the narrative.